All right, so we're going to go ahead and open up discussion, and we're going to continue the 101 discussion, the 101 instructions that we've been giving the committee. The first thing I have, though, are there any bill requests, bill introductions? All right, thank you very much for not introducing bills. I like that. Okay, now we will welcome to committee Kyle Kessler, the Executive Director of the Association of Community Mental Health Centers of Kansas, which I told him earlier today, the name's going to have to change after we have all these CCBHCs and it doesn't work anymore. So welcome to committee, Kyle.
We're excited about the prospect of that, Madam Chair. Thank you. And I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers of Kansas. And for those of you who are new to the committee, I know about a third of you are, we are the state association for all community mental health centers, so all licensed 26 mental health centers around the state, and every county has a designated mental health center. So there are some legislative districts that have as many as 3, depending on how your district looks. Many of the legislative seats around the state only have 1 mental health center. A few have 2, but there are actually 2 or 3 out there that have 3 different mental health centers. So it's not uncommon for me to hear, man, it seems like there's a mental health center everywhere. Well, only actually for you, Representative. So it's just different district by district and community mental health center by community mental health center. There, I'll actually skip to one of my later comments first. About 3 or 4 pages into the information that David distributed is a map of all the community mental health centers in the state, and there are about 9 or 10 of them that have only a single county that they serve, and then there are several that have maybe 5, and then there's another one out in northwest Kansas that has 20, and another that has 16. So you'll see that those are really a reflection of the communities that they serve and the decisions that were made years ago. And going to that history, most CMHCs date back to about the mid-1960s with the signing of the Community Mental Health Act and at the federal level, and several go back as far as 75 or 100 years. And when the Community Mental Health Act was passed or implemented, that was about the extent of the federal implementation of community mental health. For years since then, we've really been, in many ways, a state-designed and state-defined system, and most of the influence and resources we've been given were by state and county governments. We're really and now the federal government is getting into it a little bit more, and we will, I'll make reference to that later in my overview, and then Greg Hennon, the Executive Director at 4 County Mental Health Center in Southeast Kansas, and one of our resident experts on certified community behavioral health clinics will speak and give you a little bit more of an understanding of what that means to the mental health system around Kansas and the safety net that we serve. So Kansas, as it goes with mental health, and me talking about the federal government really not doing a lot to implement the Community Mental Health Act in the mid-1960s, we had the Menninger Clinic. So a lot of people here will remember the Menninger Clinic as a world-renowned psychiatric institution, and they were actually extremely involved with the implementation of the Community Mental Health Act and its development. And the first ever executive director of the National Institute for Mental Health was Dr. Robert Felix from Downs, Kansas, who is also connected with the Menningers. And so Kansas has a rich mental health history. But when the Menninger Clinic left the state in the late 1990s, out the door with that went a lot of trained psychiatrists, a lot of trained social workers and nurses and psychologists. And so the clinical loss was just devastating to our system. Now, we've been fortunate, and this also circles back to the workforce conversation, which I know you all will have probably in depth and maybe ad nauseum with this committee, because every part of healthcare, whether it's our partners in the hospital system or physicians' clinics, is workforce starved, without a doubt. So we were fortunate when the Menninger Clinic relocated to Baylor, the Baylor Medical Center in Houston, Texas. They didn't take the state of Kansas with them because a lot of people decided to stay here and raise their families. And now they are getting to retirement age. So we're looking to replenish that pipeline of social workers and psychologists and nurses and psychiatrists and nurse practitioners that we really rely on through our system. The Mental Health Reform Act is really the first major innovation or transformation for our system, and that was passed in 1990. And this really set the tone for our state design and state defined system that I referred to earlier. And the idea was to close state mental health hospitals, which probably any of you who visit with hospitals and their emergency room capacity, and law enforcement and community mental health centers have heard about the closing of state hospital beds and how that has gone over the years. The idea with mental health reform back in 1990, and one of your colleagues was talking to me 3 or 4 years ago, and he said, you know, I wrote the darn bill, and I thought he was being colloquial, and then I went back and researched, and he was actually really involved in writing the bill in 1990. And so with that bill, we showed a lot of foresight in how we intended to go from several hospital locations around the state to community-based services where people would be able to receive services and treatment, and their families could be engaged in their services and treatment in their home communities, or at least as close as possible to it. So what I would call the Mental Health Reform Act was an incredible blueprint that a lot of people, a lot of states around the country tried to emulate. But then it was incomplete public policy because instead of transferring those dollars from the hospitals, which was the intent, was for them to go to the CMHCs and to provide outpatient treatment and services and medication management and also prevention-oriented activities, then we started cutting things off. And we said, okay, instead of transferring those dollars, we're going to keep one for the state and give you guys one. And then we'll keep 2 and give you 1. And then we'll keep 3 and give you 1. And this kept going until the early 2010s. And really about 6 years ago, there are leaders on this committee that really have taken leadership roles in helping us to reestablish the community mental health system. And now what we're working on are several, not just the CCBHC initiative, but 988, crisis services, the school mental health intervention team programs. And these are, again, things that we'll allude to during the course of our overview. But a lot of people, we're getting calls now saying, hey, how did you do that again? And there are states like Indiana and Montana, West Virginia, that all said, yeah, we're basing our CCBHC legislation off Kansas-style legislation, which was bipartisan but overwhelmingly led by the legislative leadership and the committee chairs at the time and ranking members of those committees. So it's really been something special we've been able to accomplish in trying to make behavioral health a source of pride again for Kansas, and something that other people will ask us, you know, how we're going about doing things and how our legislation was designed. Just to go back to the state hospital issue, because you will hear more about that. I know there was an interim that a few of you served on with the state mental health hospital beds, and in Wichita there's a recommendation, I believe in the governor's budget and out of that legislative interim, to put approximately a 50-bed mental health facility that is either state contracted or state owned in the south central Kansas area. And so just for context, we had approximately, at its largest, some of you will see off of McVicker, that area, a large group of buildings that now have any number of different uses, but it was the old Topeka State Hospital grounds, which was also used, and at its height in 1972, it had about 545 beds. By the time it was closed 20 years later, it had about 230, and now we have 0 beds there. Some of you are familiar with Rainbow Mental Health Facility in Wyandotte County in Kansas City, Kansas, that had 50 beds, and in 2013, that was closed, so there's 50 less beds, so there's about 600 beds that are totally off the map. And then both Osawatomie State Hospital and Larndon State Hospital, which serves western Kansas, both had many more beds than they do now, but now those two combined have about 250. So we have about 20 to 25% of the number of beds that we once had, and we've leaned more and more on the community mental health system for things like crisis services, and recognizing that community mental health centers have to serve anyone regardless of their ability to pay. So whether that money comes from commercial insurance, private pay, subsidies from the county or state governments, and certainly Medicaid is, and private insurance, as I mentioned, are payer sources. So the diversification of community mental health center resources and revenues is pretty significant. I would also mention, you know, as I talk a little bit about the size of our workforce, workforce consists of around 5,000 people across the state, serving around 145,000 people from fiscal year 2021. And as we've surveyed our members, we see about a 20 to 25% vacancy rate, some as high as 45%. And so they are constantly in the hiring phases, and the human resources officer is oftentimes both the most popular and the most stressed person in the organization, I think. So when we started looking a couple years ago at how we could replicate or improve upon our systems, and we weren't just looking for increased Medicaid rates or additional state general fund non-discretionary or discretionary dollars, I should say, but we knew that we probably needed to do more work, and there would be additional responsibilities or strings attached to the dollars that we saw. So the Senate substitute for House Bill 2208 that was passed by the 2021 legislature, I think there was a total of 6 no votes on the legislation across both chambers, and then it was signed into law by the governor. It required that 9 CMHCs be certified as CCBHCs by the Department for Aging and Disability Services. You may have heard a little bit about this yesterday during Secretary Howard's presentation. And those 9 would need to be certified by June 30th, 2022, and then another 9 will be certified this coming June, or by July 1 is what the statute says, and then the final 8 would be certified by 2024. So many mental health centers have received, in fact, now most have received federal substance abuse and mental health services administration grants through the U.S. Department of Health and Human Services. And this seems like a really appropriate time for me to go right to our glossary and definitions list, but I'll hold off onto that for just a minute or a little bit. But the feds, for years, I would have called SAMHSA the poor younger sibling of the Health and Human Services Administration, or the Health and Human Services Agency at the federal level. They didn't get much money. Medicaid, HRSA, other areas, it seems like were better funded. And then when they did have the ability to draw down money, then that was kind of through CMS, the Centers for Medicaid and Medicare Services. And so they really had the rules to that. So they held the pocketbook. And so when the pandemic hit a couple years ago, and even then, our state was seeing a suicide crisis and seeing numbers escalating more and more as I think in ages 14 to 45, death by suicide was the second leading cause of death. So that had kept rising more and more. But federal lawmakers started seeing there being a mental health crisis nationally, and they started putting more money into SAMHSA, and SAMHSA just didn't know how to spend it. They didn't have any experience. Their budget, something I think tripled in 1 year and was up maybe by 10 times within 3. So they did not know how to get that money out to the states unless they just put it in the block grants and said, please go spend it wisely. So where they started putting that money was in the Certified Community Behavioral Health Clinic model. And just as a quick connector to that, the Excellence in Mental Health Act that was passed about 7 years ago, which was really the brainchild and legislative work of several stakeholders were involved in it, but the 2 key legislators were Senator Blunt, a Republican out of Missouri, and Senator Stabenow, a Democrat out of Michigan. And oftentimes when people ask me the difference between the Excellence in Mental Health Act and the Affordable Care Act, I will say, go look at the votes, because you had bipartisan legislation passed with the Excellence in Mental Health Act, and now whether you are considered a red state or a blue state, we are competing with each other to have the best CCBHC systems in the country. And Kansas is poised, I think, to really lead there, as I've mentioned now about 3 times. And so I think that when we saw SAMHSA getting money, and a lot of PTSD among veterans, I shouldn't leave that part out, but anxiety among youth, and then certainly the addiction issues relating to the pandemic and recent past, the opioid issues are for sure on people's minds. So when SAMHSA had that money to go out, they wanted it. We thought, well, we've got this mechanism called the CCBHC model, and so that. But there were only half a dozen states or so. Our initial opportunity to go at that was forfeited by a previous policymaker. I'll kind of just leave it at that. And it required both the State Mental Health Authority, which is KDADS, and the State Medicaid Agency, which is KDHE, to work together and submit an application to the federal government. And KDAD said, yeah, we're with it. And then KDHE said, no, we don't think that this is the right thing at the right time. So what we did was just continue to study the issue, and when SAMHSA started putting out money, then we had a lot of mental health centers that were ready to apply for those grants and have received them. I think that the only other thing that I would mention about that, and then I will go ahead and turn it over to Greg here in just a moment, is that you'll see a map at the back of your handout. It looks like this, a lot of shades of orange, and that gives you an idea of how the CCBHC model is being funded around our system. So that also provides a lot of ideas about what we're trying to fund and why we're trying to fund it, and trying to give some of the mental health centers a little bit more of an on-ramp, so to speak, and so that they're not live on day one and expected that you have to have same-day access. We're trying to do the best we can, and again, what you'll see, one of our other handouts with our issues going forward in our public policy document, in fact, it's the last page. There are several items on there that we'll go back to after Greg talks, and then Sue Mernan in our office after that, who will talk a little bit about the numbers relating to the mental health intervention team and the mental health intervention program with the schools. So I would probably just leave that for the moment, Madam Chair, and if it's okay, and I'm happy to take questions at the appropriate time, but I can go ahead and have Greg come up, or I can answer questions as you all have them.
I think we'll get through everyone, and then we'll open up to questions.
Sounds good. So I'll go ahead and introduce you to Greg Hennon, who's the Executive Director at 4 County Mental Health. Thank you, Madam Chair.
And our first CCBHC in the state of Kansas.
Thank you for the opportunity. I'm Greg Hennon with 4 County Mental Health Center down in southeast Kansas, and a little bit over into south central. We go from Cowley County back to the east. But as already referenced, we had the opportunity through one of the federal grants to become one of the first CCBHCs in the state. And I just wanted to highlight 3 or 4 kind of points that make things different for us from being a community mental health center to being a certified community behavioral health clinic. One, Representative Blex was asking me out in the hallway, well, how's workforce retention going for you? That was a dramatic change with some additional funding that we had through that federal grant, that we were able to get a little bit more competitive with the CCBHCs to the south in Oklahoma. They're siphoning off 6 and 7 and 8 of our therapists and losing case managers, and we've been able to slow that down. We can't beat them yet in the salary race, but we're competitive enough that people are able to stay with us and feel like they've got a livable wage. So that's a nice change. But the most exciting thing about the work that we're doing is really the clinical outcomes that we're seeing. And I promised Chairperson Landwehr last year that I would bring back some data to say, hey, here's what we're seeing as we're getting traction with these clinical programs. So I'm just going to cover a couple of areas. One of the key points to the CCBHC is making sure that everyone has access to care, and the care that they're getting is resulting in a functional improvement or change in how they're doing in their day. So just a few numbers real quick. 4 County served 5,669 patients last year, about a 5.2% increase in the number of lives that we're touching there. But the important part of that is we're not only seeing more people, but the timeliness of us getting services to them is greatly improved. 87% of the new admissions that come into our clinic are seen on the same day that they called and made a request for an appointment. So 87%, it's come on down, we'll see you the very day that you let us know that you needed something. And that's not something we were able to deliver before, but we've got systems in place that make that far better. The average wait time to get an appointment with us on an admission like that is 3 days. So again, we've shortened that distance. Our contract with the state says you need to get people in within a 10-day time period. So offer them something within 10 days. No, we're beating that by quite a stretch, and I'm glad to see that. 91% of our admissions occur in 10 days or less. So the 9% that aren't happening within the 10 days are patient choice. It's someone that says, hey, I want to see Greg Hennon as my therapist because I saw him 4 years ago, and I can only be seen on Tuesdays or Thursdays after 4 o'clock. Okay, so if they've got a specific time or a day or a special therapist that they want to work with, then they're the ones that aren't necessarily getting in within that 10-day time frame. But everybody else, 87% one day, same day, and then 91% within that 10-day threshold. So again, we feel really good about what's happening there with access to care. In terms of the outcomes, once they've accessed us, on the kids' side, children's side, 82% of the children demonstrated a functional stabilization or an improvement based upon just a quarterly measurement of the treatment that they received. So in a 3-month time period, we've got children that are either stabilized in their crisis situation, or we have them stratified by severity level or acuity level, and they may move from, say, a level 4 severity to a level 3 in that 90-day time period. And for the adults, it's 85% that either end up with that stabilized functioning or an improvement in their overall level of care. So it's neat to see the access, but even better yet, that we're having an impact and it's actually changing the lives of the people that we're touching. Another area besides access and functional outcome that CCBHC's emphasize is veteran services. And in looking back on this last year, when we started out as a CCBHC kind of look-alike, we had that grant money to start building these programs. We had 50 veterans that were enrolled in our services across the 5 counties. And our goal was to get our number to 100 or more. And within that first year, we hit like 137 plus 48 family members, so that was neat to see happen. But this last year, we saw a 27% increase. We're now seeing 120 veterans every quarter, not for the year, every quarter. And there's about 30 brand new veterans that are getting services from us each quarter. So 30 may end their treatment episode and say, okay, we've got that issue resolved, but then their fellow veteran comes through the door and starts that treatment with us. So 30 new veterans every quarter. And we've had 58 veterans where we've been able to provide kind of a specialized care coordination. So they're coming to us and they may have a behavioral health or mental health need, but there are other things happening in their life as well, and we're doing coordinated care with their primary care physician or their VA hospital or whatever other providers they need in order to get the best care and integrated care that they can. Third area that we work on is crisis services. There's a specific program called Assertive Community Treatment, and there we're doing a lot of outreach. We do some co-responder type work with law enforcement. We're doing some work inside the jails, but this ACT team that's out on the streets, they're working with a lot of individuals that are either coming through the judicial system or are homeless. And they can be a tough group to engage because they tend to move around a lot, a little tougher to find. But our ACT team stays on the streets and keeps engaged with those individuals. And what we found is that individuals that came to us in a crisis situation that, again, were homeless or involved with the judicial system may end up in a hospital, but after a 90-day time period, only 2% of those have relapsed and been back into the hospital. So we're 98% successful at keeping those individuals out of the hospital, and that's a 7% improvement from our performance in the previous year. There are about 60 high-risk adults that we've provided that ACT care to in the last year. 87% did not require hospitalization of any kind. 84% stayed out of a homeless situation that they originally started in, so there have been some relapse there. and 65% had no incarceration incidents. So again, this is a homeless population with co-occurring substance use disorder. So there obviously has been some legal ramifications for their substance use, but 65% no additional legal contact and no incarceration. The last thing that I'll touch on is just some general community services. One of the kind of emphasis points again of the CCBHC system or model is supported employment. So taking individuals that have been dealing with severe and persistent mental illness and not only get them to a point that they are at a recovery where they can manage their own day-to-day life, but also do some employment training, and we do job development and help them with job interviews and get them placed in at least a part-time type job. And we worked with 107 individuals each quarter of last year, had about a 38% employment rate, so they got a job and kept a job. So not quite 4 out of 10. And again, these are individuals with severe and persistent mental illness. They've been institutionalized at least once, and or they're at high risk for being reinstitutionalized or being a risk to themselves or others. So having 40% of them back in the workforce is really a neat thing to see. And what we found is those that kind of get traction in our supported employment program, their recovery kind of goes leaps and bounds. So it's a neat thing if we can get them engaged and get them successful for the first few months. It really does take off. Last point that I'll make, we do some specialized children and family services. So it might be parent support, it might be some parent education, could be anything kind of out and beyond the traditional therapy or case management that they would get. 719 children and their families were impacted through those specialized services, and that was also a 7% increase from the previous year. So I'll stop spitting statistics at you, but just let you know that we're really pleased at the opportunity, so thank you.
Greg, is that something you can get it in writing to us?
Yeah, I absolutely could. Yeah.
Thank you.
You bet.
Because those are very impressive. Now I believe we've got another person to come up and talk to us that just loves to speak in front of people.
This time she wasn't talking about me, but I mean, I'll go ahead and I want to provide a little context because Sue got all of about 4 hours to prepare to be here because one of our other executive directors who's been really involved in the school mental health program and school mental health intervention team program had another board meeting that she needed to attend today. But with about 5 years ago, 2018, the legislature adopted a proviso that established a school mental health intervention team program, recognizing the growing number of incidents of anxiety, depression, other issues relating to youth. And so Sue will go into the numbers in terms of the number of school districts it serves and CMHCs and what those outcomes look like. But it has been an overwhelming success. And certainly, again, this was bipartisan effort. I think the champions, certainly Chairwoman Landwehr and former Representative Wolf Moore, were very active in getting that going. And so Sue Mernan is our youth services manager with our association, and I will turn this over to her.
Welcome to committee.
Thank you. Good afternoon, Madam Chair and the rest of the committee. As Kyle said, my name is Sue Mernan, and I serve as the Youth Behavioral Health Service Manager for the Association of Community Mental Health Center. As he mentioned, in 2018, Kansas Legislature approved the proviso authorizing 9 school districts to enter the agreements with local community mental health centers for the 2018-2019 school year. And also provided funding for a database for students referred to the program to track their progress. The one-year pilot program was established to address challenges schools were experiencing through increases in students and families with mental health needs. And the program has since grown and now includes 67 USDs, school districts, and 19 community mental health centers. The Mental Health Intervention Team program helps eliminate barriers for students and families to access services. And as we're developing this program, we're hearing so many success stories, so much about just removing the stigma associated with going into a mental health center. We're really reaching a lot of families and children that would not have accessed it in any other way. Other barriers that it has eliminated is children missing school to travel to a mental health center for an hour-long appointment and then traveling back to school. And sometimes they didn't go back to school for the day, so they were missing out on a lot of educational opportunities during the day. Another one is parents missing work to take the youth to school. And that was another issue that we eliminated by putting the community mental health centers in the schools to provide those services. Another was access to foster care youth, eliminating the need for foster care agencies to provide that transportation or foster care placements to provide that transportation to get the youth to school as well. So in looking at the numbers, as I mentioned, the initial year of the program, which was the 2018-2019 school year, there were a total of 1,708 youth receiving services through the MHIT program, and that consisted of 9 school districts and 6 community mental health centers. The program included, the next year was increased to 32 school districts and 14 community mental health centers, and during that year of the program, there were 2,585 youth served. During the third year, which was the 2020-2021 year, there were 55 school districts and 16 community mental health centers, and over 5,100 youth were served through the program. Now, what we handed out today is the preliminary results of the first semester alone of this school year, the 2022-2023 school year. And the initial semester, July 1 through the end of December, this program has touched 4,863 youth, which is almost as many that were served last year in its entirety. So, thank you.
Actually, I monitor that on a regular basis, so I had it before, I had it early. All right, okay, Kyle, do you have more, or are we ready for questions?
I think we're about ready for questions. The only other thing I was going to mention was that our system, again, is extremely unique, and so you just heard about our collaboration with the State Department of Education, and someone was talking to me last year about, different government agencies and oversight and regulation, and I said, man, get out of here with your week 1 and 2 state agencies that you work with. We've got about 6. Between State Department of Education, the Department for Children and Families, the Department for Aging and Disability Services, the Department for Health and Environment. Sue actually has a contract she runs. She also does our mental health first aid. If any of you have heard of that prevention program, which has been very successful through the Department of Corrections, and now there's also mental health money in the State Department of Agriculture. So to deal with farmer and rancher mental health that was part of the last Farm Bill. So it's gotten more and more to not where is mental health at, but sort of where isn't it. So with that, Madam Chair, we would answer questions.
All right, we have Representative Blacks.
Thank you, Madam Chair. Greg, if I can give you a question and a comment. Personally, committee and colleagues, I'd like to really compliment this man. It takes a lot of courage as a CEO operating to send your employee from a work site, professional work site of Fort County to a local, what a lot of people refer to as a bar. Mm-hmm. And what he has done innovatively, and I have personally seen this, a huge impact. He mentioned the number of veterans. Executive Director Hennon has allowed his an employee to go to the local VFW service organization and working, Tuesdays and Thursday nights, I believe, from about 4 till 9 or 5 till 9, when most people go home and quit. And what that has done, and I can personally attest to it, I've seen people and had a lot of people comment, a lot of people that would never enter Fort County's walls as a mental health facilities will go from that bar to a private, and I'm using the word lightly, I guess, probably shouldn't, but that's what it is to me. I was sorry. My mother taught me you don't drink, smoke, or chew, or go with girls that do type thing, so that still kind of stuck with me. But basically, those people can walk 10 feet and go over and get help. And that has been a tremendous, I've had more compliments of that, and I commend you, because that took thinking outside the box to deal with that. And that's one of the reasons why Montgomery County has really stepped, and Fort County is heavily involved in a veterans program of looking at, and that's the reason why we're seeing those increases. and success stories. And I want to publicly compliment you because compliment you. It has really, I think, turned a lot of people's lives around, and it took a lot of courage to do that. So thank you. Thank you, Madam Chair.
Thank you.
Representative Clifford.
Thank you, Madam Chair. For Kyle, recently we had a grant in Finney County. I was on the Compass Mental Health Board for 7 years, as you know. The grant went to our FQHC to provide mental health services at our community college. And I'm wondering, you mentioned the USDA money, because we haven't converted to a CCBHC, are we not able to access those federal dollars, or was that maybe a one-off where it went to the FQHC instead of what I consider to be the correct place?
Representative Clifford, I think you answered your question twice, because the answer is really both. I mean, there are quite a few, and our counterparts in the federally qualified health center world do quite a bit of behavioral health work. And as the safety net, it depends on what someone is looking for and what they write into their grant. The majority of those grants that go for after hours, weekend work, crisis center things are awarded to community mental health centers. So, but going back to what you said, and I know that Compass is right on the cusp of this. I mean, they're ready to do this. One of the things, and Lisa Southern's one of our rock star executives across the system from there, and so even developing a children's crisis center, and that's another part of the system that I didn't even mention. You know, as a result of all of these state hospital beds we had lost, we designed a crisis center model, which started really at Rainbow Mental Health Facility in lieu of that, and now we had one crisis center 7 or 8 years ago, and now we've got 9 or 10 across the state. So those mental health centers that have those are in an even better position to be CCBHCs.
Follow-up, Madam Chair, since you mentioned Lisa Southern's name publicly, I'd put Lisa up against Doug's director.
Yeah, no, they're both terrific. Since I work for both of them, I love them all equally. But I think that to say that what Compass is also doing with youth mental health care and behavioral health care has been just so significant, but we're seeing that really all around the state, and all of these folks get together. We have 8 or 9 board meetings a year. We have a reception tomorrow evening after our board meeting, and they're trying to raise the bar. I mean, it's a friendly competition and it's a collaborative environment, which is a good thing.
Thank you, and thank you, Madam Chair.
Let's see, Representative Epley.
Thank you, Madam Chair. And this is for Kyle or Greg, whoever wants to take this question. It's about our new 988 legislation that we passed in the last session, and how that may be siloed from the CCHPCs, I don't know, but I was curious if there's a communication or dialogue, or, if there's a referral through the 988 hotline, how that gets eventually to one of the mental health centers, either the new ones or the old ones.
Yeah, I'll take an initial stab at it, but then rely on Greg to clean up what I say. But and so I think that the CCBHC model is making it that much easier for the 988 legislation to be implemented, because it provides, again, more after-hours resources. There's, I believe, 3 988 call centers around the state. I mean, and it's one more reason why we want to see, and one of the things we'd hoped to see in the governor's budget was the acceleration of the CCBHC plan, because the legislation says you have to have these implemented by these dates. So whether it's Compass or others, Guidance Center's another one. I mean, if we could move those up and get more of them going, then we would just be accelerating our successes as far as I'm concerned. But do you want to comment a little bit on that, how you guys work with the 988, the suicide centers?
I can, just real briefly. I don't know that I have a whole lot to add other than having the additional crisis services, that ACT program I spoke of earlier, and doing the co-responders with law enforcement. When those calls come in, we're just better equipped to go out and meet people where they're at, and not worry about them coming within the walls of our mental health center. What Representative Blex was talking about, we go to the VFW, and our liaison is talking to people where they're at, and they just walk across the street to an outreach office, and we touch base with them. We do that the same thing with the crisis services. So the 988 calls that come in, we're out in the community doing that, not making them come to us. That's the biggest difference for us.
Madam Chair, one more question. Thank you. So, gentlemen, same kind of thing. So when you get a referral, how's the referral made? Do they contact you, and do you have crisis intervention teams yet, or do they have their own? Is that in parallel, or are you the ones that deploy a team?
Yes.
I'd like to hear how that works.
Yes, when a call comes in, it may come in through Health Source Integrated Solutions. They do an answering service for us and then contact our crisis team, like you said, and then we send that team out. And we may do that on our own, or we may do that in conjunction with law enforcement, depending on what the circumstance is.
And again, Greg, I want to make sure that the committee understands that prior to 2 years ago, that was not a capacity.
No.
That was not happening.
No, that was not.
So this is all a new game for us, if you will, in
Yes.
mental health. Is that correct?
Yes. What we did prior was that we had a crisis therapist and a crisis case manager, and the patient would either come to our crisis service building, or we would go to the ER and meet them there. It was one of those two places.
Correct.
Now it's anywhere in the community.
Okay. Thank you very, very much.
Yes.
Representative Hesswood.
Thank you, Madam Chair. These questions are for Greg. You said a couple things that perked my interest. So I come from Lawrence, and I feel like we can do a lot more for our veterans. Did you see any correlation with the veteran services, with like veterans court? I know sometimes mental health and the justice system can go hand in hand.
Yes. We have not seen that where we're at. We do have a mental health court and an outpatient, a mental health court and an alcohol drug court. Those are both happening in Cowley County, but only in that one county. There's not a veterans court, if you will. We've done some exploration of that, but it's not been implemented. So all of our work has been with, again, the liaison that goes out, and he's a 20-year retired vet himself. So he has a lot of street cred with those gentlemen and ladies. And just being the face of mental health that has that legitimacy, once they trust him, they're willing to trust us. And that's really been our connection. But we've not had a lot through the judicial system.
Thank you. Madam Chair, if I have one more question. You mentioned working with homelessness. How does that look? Because I know where I'm from, there's working with the local shelter. Not every county has a homeless shelter, and with beds being paid at the local hospital. How does that look in your area? And is there any barriers at the state level or areas of opportunity that we can look at?
I may have to think about that in terms of areas of opportunity. In our area, there aren't a lot of formal shelters. There is a ministry home where they can take 7 or 8 men that are homeless, and there are some support ministries as well for women and children. But a lot of those that we dealt with, again, through that crisis service, are people that are not looking for shelter. They're involved with the legal system because of whatever behavior or alcohol drug involvement they've had. So we become aware of them through the law enforcement. Yeah.
Thank you.
Yep.
Representative Berquist.
Thank you, Madam Chair. And for either one of you, probably you, sir, again, when a crisis call comes in on the 988 call and it's referred to you, and a crisis team is sent out, do you have access to any historical, other than the individual themselves calling in, historical treatment that's already happened, or psychotropics they're already on, or anything like that?
If they have a treatment history with us, we have an electronic health record that we can access out in the community, whether that's through an iPad or on a phone. It's cloud-based, so we can log in and access that. If it's outside of that system, no, we don't know if they came from 100 miles away and they're just passing through and we're touching base with them. We don't know what their history is.
Very good. Sounds like it's a lot better than lot better system than it could be if you didn't have the 988. Sounds like it's a good deal. Thank you.
Yes.
Representative Reese.
My question is for Kyle. Kyle, I know this is, I'm sure this is way too early to tell, but as of yesterday, any veteran who presents themselves in crisis to any hospital, community mental health center, can now receive reimbursable services. It's a 30-day is it 30-day inpatient, 90-day, up to 30-day inpatient, 90-day outpatient. And I know this just started yesterday, but would it be a way to track whether we're going to see more veterans seeking services?
Well, and I was getting ready to say, I was afraid you were going to ask me how it was going to work, and I would have said, Representative Reese, I would have been disappointed if you didn't ask me something I didn't know the answer to. But for this particular situation, we think that we will be able to track it much easier with the CCBHC model. I mean, what Greg's been able to do in other mental health centers, and this was actually on a thread last night among the mental health center directors saying, what have you heard about how this will work? Because the VA hasn't always been the easiest for us to collaborate with. And I think most providers and hospital systems have had that experience. So that's one of the really special things about this new model, and working again with the VFWs. And just like Representative Blex couldn't have said it better, but if you run into Joe and he says, hey, I'm doing okay this month, but my friend Bob, he's having some trouble. So you get those referrals, the referral pattern's magic. So I think that's how we're hoping that this new veterans access process will work as well.
Thank you so much. Thank you, Madam Chair.
Representative Epley.
Thank you again, Madam Chair. Just real quick, and Kyle, just update kind of for the newer members, because I don't know how much they know about the legislation last year. When will this be fully functional for all community mental health clinics to become CCHBCs? And also, are in the industry for mental health throughout the United States, are there metrics by which we're going to be able to measure the efficacy and the progress of these new mental health clinics?
Yeah. So last question first, partly because I don't completely remember the first. But I think that with that second question, we will have the opportunity. There are more and more data warehouses, and we're looking at that right now in Kansas. So my hope is by halfway through this legislative session, we'll be able to give you an update on what the outcome stuff will look like. That's something that Chairman Will Carpenter was absolutely a taskmaster on the last couple of years, and others who have sat in his committees have heard that. He wants to see the outcomes. And so we're totally good with that, because it will not only help us show why we've improved our system, but where some of the weak spots may be, where we can improve and provide more access to the people and families that need them. So, yeah, sorry, go ahead. First question.
First question was, not trying to confuse you, but just so for the new members, when will this program, this system that we're rolling out in 3 years, when will it be at full potential and fully functional?
So here's an interesting thing, and I think that I started responding to your question in my head and then started listening to your second one. But with that, the full implementation of the legislation will be June 30th, 2024. But there are only probably 2 mental health centers that are saying that they would like to wait up until June 2024. So either some that would like to start by April. So, and we look at that kind of for us by quarters. So the quarters of the year, you can maximize your funding and being able to track things. So I think that we could potentially have 23 or 24 implemented by maybe January of 2024 if we are able to accelerate the program.
Thank you very much. And that's out of a total of 26, if I'm remembering
26,
correctly.
correct.
Yes. Thank you very much, Kyle. Thank you, Madam Chair.
Thank you, Mr. Vice Chairman.
Committee, are there further questions? Representative,
Just scratching my head.
well, see, Representative Burkamp, we're not used to having a representative down on that corner that asks a lot of questions, so just be careful. Representative Henderson was very, very quiet, but please, go ahead.
Thank you.
I'm razzing you.
Thank you, Madam Chair. And this is kind of an off-the-wall question, but in the last 2 to 3 years, Johns Hopkins has been given a lot of money to study psychedelics for PTSD and alcoholism. I'm just curious if you followed any of those studies, or if you think there's any potential down the road for the state of Kansas to go down that path as well.
It's gaining momentum in terms of the conversation compared to where it was 3 years ago. I think microdosing and stuff like that is maybe what you're talking about. And I know there are some states that are probably more receptive to it than what we have been in terms of what we've looked at. You know, I mean, again, for the 8th time, I'll mention CCBHCs, and we really had patterned that after a model in Texas and trying to build on it. But some of the, I don't think that we want to turn our back on any potential innovative treatment methods. I don't know if we've had much conversation really about it, though, at the system level yet. Thanks, Representative.
Thank you.
Can I mention one other thing, Madam Chair? Going back to a question that Representative Hasswood asked Greg, please?
Sure.
All right, thanks. I'd say please. But one of the things that you mentioned, we actually have one of our policy initiatives is related to supported housing. So in the same way that Greg talked about the importance of supported employment, and we can help get people back to work, supported housing will help, does the same thing for people who are homeless. So if you can support people's housings, and it's maybe helping them find housing, helping them know, you know, when to clean and when to pay the utilities and just keep them organized, then that ends up being a long-term savings because they don't end up in law enforcement engagement or emergency room involvement. And so, and there, I know in Douglas County right now, there's a lot of moving parts to the behavioral health scene, and they're working on a lot of things. Thank you, Madam Chair.
Committee, are there further questions? Kyle, are we still of the impression or belief that we'll have one CMHC that may not become a CCBHC, or do we think they all will?
Currently, and what we've also done is establish a CCBHC technical assistance team, and it has one of our former CEOs who was also an early adopter right behind Greg of the CCBHCs, and so he's leading that effort. And so, and then Dr. Will Warrens, who's one of our psychiatrists and has been around the block and knows things, he's also the medical liaison on that technical assistance team. So, I mean, this group is going around, and as of right now, and skipping to, it wouldn't be a conversation with you if I didn't provide a really long answer to your simple question. But the answer is we now think that all 26 are going to adopt.
That's pretty exciting.
It is, because there were a couple that were pretty open about, we're not sure if this is going to work for us, but now one of those has a SAMHSA CCBHC grant, which will lead them in that direction. And then the other one is saying, yeah, we're all in, and they're really an innovative small center as well. But they're probably one of them that's leaning more towards the July 2024 date.
Well, I think committee members, one of the things that some of us that have worked on this for a while understand is our CMHCs were funded previously by Medicaid reimbursement rates. And those are very low. With this CCBHC, then they are funded more like designation. They're funded more like our FQHCs, which means it comes in more at cost. That's kind of the simple explanation of it. And that's why there's more money then available for them to retain and hire their appropriate people. We've had in the MHIT school program, we were losing some of our social workers to our school districts because they could pay more than what our CMHCs could. And we actually had one of our new CCBHCs down in my area that got 4 of them back. So because, you know, people, you know, love the work that they're doing on some of this stuff. And Kyle, you can answer it, or Sue can, but I think the shock that my ranking here to my right had was the number of students served this year versus the number of students served last year. So we did not hear that wrong, did we? It is more than we served all year long in the first quarter. That's correct.
In the first semester.
Okay. So is the bulk of that showing up in our foster care children, or, because I'd heard that we were seeing improvements in that.
Yes, and the numbers on that report don't necessarily reflect the accurate numbers for foster care youth. The number is higher, but there has been some discrepancy on how on how it was reported. So we're still working on those numbers. It's actually higher. The foster care number is higher than what that report indicates currently. currently, which I'm super excited about. I think a lot of the reason that we're seeing an uptick in the numbers of youth being served, not only because we've added districts and CMHCs to the program, but we're also doing a lot more mental health first aid training of our teachers and our school personnel in the schools. And so they're able to identify the early signs and symptoms of some of these conditions, these crisis situations, and referring youth. Another thing that we're seeing are, with the stigma being removed from mental health, kids are referring themselves. We have a lot of youth that are going and asking for the assistance of the MHIT program and initiating the services themselves. There's Teen Mental Health First Aid. And Teen Mental Health First Aid is a newer program that it teaches youth how to be a support for their friends. And so when issues are coming up, they know how to connect them to the appropriate resources in the community. And it's new and it's up and coming. That's another program that has been helpful in just initiating some of those referrals as well.
Well, and I think when this program first started, one of the problems that we were having was we didn't have the ability, because of whatever reason, I'm not going to fault anyone in particular, was getting the information on our foster care kids, and I think that Secretary Howard has really helped with that. And because when this program started, the foster care children were our what we referred to as our alpha group, and then we had the beta group, which was our our high needs kids. But we've been able to expand beyond that, and the way that this program is paid, besides some SGF in there, is with Medicaid dollars, with the CHIP dollars, with private pay insurance, and then we still take care of those that are uninsured. So no child is turned away. And I remember down in Parsons when they mentioned to us that they had people, because it's in the school building and the stigma, as you referred to, that families can come in, because this can be a true wraparound, because you may find that the families, the stress, the issues that the children are dealing with may not be a long mental health issue, but it's because there's a lot of stress at home and mom and dad are struggling, and sometimes it's a matter of, food in the house, making your rent or whatever. Is what services can this model connect them to? But they get to come into the school and receive those services. Well, in a small town, if anyone's lived in one, guess what? Everybody knows your business. But now they have no idea that, they're walking into their kid's school, and that's it. So that, it was something that I guess we should have thought about, but, it was just exciting to hear. And at some point, you're going to hear from some of our liaisons that we have out there, but one of the things that always gives me chills is the number of lives that we have saved that may not have been with us. And that's the most exciting part about this program. So we couldn't have done it without Kyle Kessler. I drove him totally crazy trying to get that done. But I have to say the Department of Education and all the agents that we had involved just came to the table and they helped to make this happen. So, okay, let's see. We've got Representing Burkamp. Huh? Well, you'll get again. You want to go before Burkamp? Go ahead. No, Representative Epley, your mic is on.
I'm sorry. Thank you, Madam Chair. So just my question, this is a segue off my chairwoman, and thank you for coming back. Are there metrics that you've developed to measure a decrease in behavioral referrals for these kids served? And also, I mean, I can see that, but can you say, has it been long enough that we can see a big decrease in suicides in those areas served, or not? I mean, do we have ability to really measure that yet, or not?
I'm going to intercept a little bit just to say we had actually seen a drop in suicides right before the pandemic. Now, whether we can say definitively that it's because of this program, well, I don't know that we can say that, but something was leading to a reduction in the number of suicides, and then the pandemic came along and it's kind of started creeping back up. But I think that we do feel like there have been several reports of people saying, like a child actually in the Leavenworth County area had brought coffee to a teacher and stuff, and they started thinking, what's this? This is kind of weird. And that was a child that was coming up with a plan. Right. So, I mean, these are general comments, obviously, and so a lot of it ends up being anecdotal. But in terms of looking at the numbers of the vital statistics, summary of vital statistics through KDHE, that's something that we are looking for every fall when that comes out. And I start bugging people, have we checked the website? Which means, have you checked the website? And so then they get into a habit that way. But I think that for us, I don't think we have any doubt that we know that it's reduced suicides, we just don't know the number yet, that we don't know the end.
Sure. Okay. Thank you for responding to that. Thank you, Madam Chair.
Well, and one of the things that was, amazing was when COVID hit and our schools shut down. And this is one of the reasons this program was kind of started, because even if you have counselors, social workers, et cetera, at schools, they're only available during school hours. When the schools shut down, guess what this program did? This program was reaching out to their kids. These kids were still receiving services. And that was amazing. I felt sorry for the other kids, but we were blessed, I think, in Kansas to have this available. Representative Burkett.
Thank you, Madam Chair. On the students part still, is there a goal for increasing the number of counselors, I guess, across the state in school districts, or what's kind of the
number of
plan
what?
there?
I'm sorry.
Of counselors at schools across the
Yeah,
district?
so there's an additional $3 million in the governor's budget to add school districts to the program, and we're meeting with the State Department of Education every other week, and there's an application process that takes place in the summer, yeah, in June, and last year, I think they had funded all the schools that wanted to take part in it, and I'm a little remiss in not explaining that there are quite a few mental health centers that have pre-existing relationships with schools, and they don't really want to take part in this because they already like what they had going and they figured out how to fund it. So there are some of those that aren't part of this, but this has brought a lot to the table.
And just one quick follow-up. And so kind of to touch on what other people have mentioned, I agree that I think that these kids need these resources because there's a lot of traumatic experiences that they go through, and maybe they don't have that help necessarily immediately available. However, on the opposite side, I think there are kids who take advantage of the system. So is there a way to kind of scorecard, here's kids who just maybe have general anxiety that are kind of abusing the system and are repeat where, because in my experience, I think kids are going to try and find a way out of class or things like that. So how do we kind of balance the two as far as what we need versus what's excess?
And acuity is one of those things. It started, I think, our first conversation, Diane Jerstead, who worked for the Wichita Public Schools, and Representative Landwehr, and the former superintendent for Wichita Public Schools. We were talking, and he said one of the hardest, you can correct me if I'm wrong, Madam Chair, but he said one of the hardest school ages to recruit for now was kindergarten. It used to be, you had plenty of people who wanted to be kindergarten teachers, but kids were coming in such rough shape that one student might take up 90% of the teacher's time. And so I mention that simply because trying to figure out the acuity of a student, if there's one that needs help today and maybe they're moderate or generalized anxiety, they may be tomorrow suffering severe anxiety and not able to get out of bed. So any prevention-oriented activities, and you'll hear more about that from us as well, because one of the places that we lost track, as I mentioned earlier, Representative, I'm glad you asked this question, because the prevention stuff is really something that helps, the old saying, the ounce of prevention is worth a pound of cure, or something like that. You can correct me, or any of the doctors can correct me if I'm wrong. But I mean, I think it is certainly something for us that holds true. And so even if we're seeing a child who's trying to get out of class, wonder why are they trying to get out of class? And why is the teacher okay sending them out of class? So there are a couple of different questions that are posed and then hopefully answered with the program in that manner. And so hopefully they realize class is way better than having to talk to a therapist about my feelings. So, I mean, maybe not. Maybe they need to. Thank you.
Yep, thank you.
Well, and those, I think Kyle hit on it, is those are all things that get watched and monitored. And this program, when a school gets involved, they hire what we refer to as a liaison. And that liaison then is the one that works with the school and the CMHC or the CCBHC to get the counselors in there. One of the goals in this as well is to keep schools from having to hire so many counselors. Unfortunately, that's not what they're doing, because schools can bill Medicaid. Schools can bill Medicaid. The thing is, it's a lot smaller number than even our Medicaid reimbursement rates. What schools cannot do is they cannot bill CHIP, which is our Medicaid children's health insurance. They can't bill that one. They can't bill private pay. So this program comes in, and not only what it's doing for the lives, but there's a benefit on the funding that it's not all having to be on the taxpayers to take and do that. And it also then keeps our CCBHCs and our CMHCs out there operating at capacities that they belong at, because this is their job. A CMHC or a CCBHC cannot turn anyone away. It operates just like an ER. You walk in their door, they accept you. Correct me if I'm wrong, Kyle.
Yeah,
Greg?
Greg says yes.
That's what I thought. And people don't realize that, but I think that's also law, isn't it, Greg? Yeah, so that's law.
And
Just like an ER cannot turn anyone away, irregardless. The CCBHC and CMHCs are the same way. And Sedgwick County, Johnson County, and I think there's a third one that's Crawford, that's county
County-based.
operated.
That's right.
The rest of them are,
501c3 not-for-profits.
and if you ever want the history kind of on our CMHCs, KHI did, was it their first mental health task force report that they did a few years back?
Yeah,
We
that's
may have
correct.
to go back and look at that year. I'm sure that staff can figure out which one that is for us. They did a great explanation on how our CMHC started and why they're structured the way that they're structured. Also, a great explanation as to why Rainbows Up Northeast is structured a little bit different than others are. So there's some resources, and if you want them, don't hesitate to ask one of us that have been around a while, or our wonderful staff, on where to find those. And even myself, as I went back and started reading those task force reports, it was like, my gosh, I'd been around here a while and I didn't recall that, or I had forgotten this piece here, or whatever. But that's another good way to kind of pick up this stuff, and it's not hard reading stuff, and you can kind of pick in but then I'm kind of a nerd on that stuff. It's kind of like me reading the Gannon and Montoy school cases from the Supreme. So, committee, are there any further questions from anyone? Greg, Kyle, and Sue, I want to thank you very much for being here today. And I know that we're going to have you back at different times, because this here is, the mental health is just, there is not a budget in the state, and there's not a business that has a budget that is not impacted by what happens in mental health. Loss of productivity, tardies, lateness, just flat not showing up at all. I guess tardies and lateness are the same, aren't they? Not showing up at all, not producing when you're working. Absenteeism. It all impacts our budgets and our bottom lines, not to mention what it does for the individuals. And I think it's so much more prevalent today, and a lot of it has to do with the fact that we're dealing with the electronics, and everything's faster and everything's now. And if you think about bullying, when I was in school, you got bullied and you went home, it was over till you went back to school the next day. Today, you don't escape it. Social media keeps you front and center. It's sad, it's disgusting, it's awful. I despise bullying, I despise cliques. So it's no wonder, our kids are dealing with more turmoil. We have, a lot of things that happen in, individuals' lives that are disruptive. So I can't thank you guys enough for all your work, and all of our folks out there that are working on this, and appreciate you being here today. So thank you very much.
Thank you, Madam Chair, members of the committee.
All right. I don't think we have anything else, Dave? We don't have anything else on my list there, so. Okay, and we do have a meeting scheduled for tomorrow at 1:30?
Yes.
Oh. Oh, so we have the Kansas Medical Society and KDHE that'll present to us tomorrow. So committee, we are adjourned until tomorrow at 1:30.